Hello, Dr. Russ here with episode 3 of Let's Get Paid and Stay Out of Trouble. Episode 3, Treatment Codes. How do we communicate with the world, especially insurance companies, about what we did for the patient? A treatment code. How do we communicate about why we did it? That's your diagnosis code, which was episode 2. Make sure and check that one out if you haven't already. The diagnosis codes are so numerous. There's tens of thousands. The treatment codes are way fewer. There's maybe 20 that you're going to use. You'll have them memorized if you don't already. They're called CPT codes. CPT is for current procedural terminology. It's a fancy way of saying treatment code. All of our CPT codes are 5 digits long, with the exception, of course, there's always an exception, of wellness care. There's a whole set of codes just for wellness care, and we'll talk about those at the end. They're a little different because you don't submit wellness codes to insurance. Those are for self-pay, non-insurance claims, time of service, cash patients, whatever you want to call them. So other than the wellness care, which is down here at the bottom, the 3 types of codes that we use are for adjustments. So the chiropractic adjustments have its own set of codes. We have a bunch of different codes for the therapies that we do. Massage therapy, manual therapy, ultrasound, hot and cold, electric stim. There's even codes for teaching someone how to get up and down out of a chair without hurting their back, teaching them how to properly tie their shoes or what kind of footwear to look for if they're a runner, things like that. And then the third type is exam codes, which are more formally called E&M codes. E&M stands for evaluation and management. So those are the 3 main kinds of codes, and then the wellness codes, which we'll talk about a little later. Like I said, all those codes are 5 digits long. Some of them need these little 2-digit or 2-letter appendages at the end. Those are called modifiers, and we'll talk about the modifiers too. They're really, really important. You usually don't get paid without them. One example of a CPT code that you will use is the code 98940. 98940. And that is the code for adjustment to 1 or 2 regions of the spine. There's also CPT codes for other types of adjustments. 98940, like we said, is 1 or 2 regions. It goes up 1 digit, 98941. That's for 3 or 4 regions. 1 more digit up, 98942 is for 5 regions. And if you want to count 5 regions of the spine, it would be head, so that would be TMJ or occiput, cervical, thoracic, lumbar, and pelvis. And if you were going to bill a 98942 for 5 regions, you would need to have 5 spinal diagnoses in the file on the claim. You would need to have 5 areas, all 5 regions having findings. It doesn't have to be symptoms, but it has to be findings. This goes back to our diagnosis episode 2. It's a callback where your findings could be restriction of movement, asymmetry, pain, tenderness, textural changes, usually some combination of those things, indicates a joint dysfunction underlying. You need that diagnosis for justifying an adjustment. You can also use sprain codes to justify an adjustment, FYI. And then down here, 98943 is for extremity. And so the extremities are everything from the sternoclavicular joint to the fingers, everything from the hip joint, femoral acetabular joint, to the toes, and also includes the anterior rib joints. Those are considered extremity joints for coding purposes. Interestingly enough, there's a difference in your CMT code. And don't get confused between a CMT code, which is for chiropractic manipulative therapy, which is a type of CPT code, which is current procedural terminology. So the CPT code, that's the term for all of the treatment codes that exist. And there's treatment codes, as you can imagine, for everything, including withdrawal of a snake fang. I'm sure there is a CPT code for that. CMT codes are a very small subset of CPT codes, so don't get confused if I throw that term in there. For the purposes of using the CMT code, a segment is not a region. If you adjust C2 and C5, that's one region because they're both in the cervical spine. If you adjusted all 7 cervical segments, that's still one region. Here's an example for you. Let's say a patient comes in and they have stuff in their cervical thoracic junction, middle back, and thoracolumbar junction. And you assess and you find and you fix T1, T7, T12. All 3 of those are thoracic segments. So even though you adjusted 3 segments and they're very different segments, pretty far apart from each other, that's still just one region. That's a 98940. Now let's say I took that T1 adjustment. That T1 adjustment became a C7 adjustment, just one level up. And that T12 adjustment became an L1 adjustment, just one level down. So now we adjusted C7, T7, and L1. That's 3 regions. And you would code that 98941, which is chiropractic manipulative therapy of 3 or 4 regions of the spine. And that is significant because it pays more when you adjust 3 regions than when you adjust 1 or 2. In September of 2023, when I'm making this video, these are the Oregon Workman's Compensation fee schedule fees for 98940, $63.78, and for 98941, $89.29. So you get paid $63.78 for your first 2 adjustments, and then you get paid another almost $26 for that third one. I didn't make the rules, I'm just telling you what they are. When you use the CMT codes, don't give in to the temptation to upcode. It's not going to pay in the end, and you're going to learn why as we go through this episode. The next type of code that you're going to use are the therapy codes. They also start with 9. There's 2 main kinds of therapy codes. We're going to have to break this down a little further. This is really, really important to getting paid and doing this properly and staying out of trouble. The 2 types of therapy codes are timed codes and untimed codes. The untimed codes are billed only once per visit. It's like a hot pack, a cold pack, unattended electric stim where you just put the pads on and walk away. It doesn't matter how long the patient had them on there. It doesn't matter how many regions you do it to, how many times you move the pads. Those are unattended. You are not there one-on-one with the patient. You can only bill it once per visit. The timed codes are billed based on how much time you spent doing that thing. And it's because you did that thing with the patient one-on-one. It was you there with them the whole time. So manual therapy, myofascial release, neuromuscular therapy, trigger point therapy, massage therapy, one-on-one exercise therapy, one-on-one activity of daily living counseling, things like that. Those are the timed codes. Untimed codes, once per visit. Timed codes, it depends how long you spend. Now let's talk about that in a minute, but first let's look at the really common timed therapy codes that chiropractors and physical therapists use. You may use others. These are the main ones. The use of them is the same. You just need to know whether it's timed or untimed and like what it means. I'm just going to take a second here to talk about this code 97112, which is neuromuscular re-education. And it's a code that chiropractors like to use because it pays more than 97124 massage therapy or 97140 manual therapy. But if you look at the definition of 97112, it's for rehabilitating people who have had neurological injury such as stroke or autoimmune issues with the nervous system like MS or degenerative neurological diseases like Parkinson's. It is not for teaching someone neck extension exercises. In the long run, and remember, our practices are sustainable, in the long run, this is going to come back to bite you. If you're a network, your insurance company contract says they have the right to audit your files at any time, and they can go back and rescind whatever payments they made, and they will withhold that money from future payments for you. Just don't use that 97112 unless you are rehabilitating stroke victims and people with Parkinson's, then by all means, use that code. So let's talk about the codes we do use. 97110 is exercise therapy. So using therabands and range of motion stuff with people, going through stretches with people. I have the Pilates reformer in my office, and we would do Pilates with people rehabilitating from injury. 97110. 97140 is manual therapy, which is things like myofascial release, trigger point therapy, craniosacral therapy would fall under manual therapy. The 97124 is, there's a lot of overlap and it's kind of a gray area, but 97124 is really just more for like traditional massage strokes, like the Swedish massage and the tapotement and the effleurage. That generally is 97124. And then the main two PT codes, the modalities of ultrasound, 97035 and 97032 for electric stimulation attended. You are there applying it to the patient, or your assistant is there, but you're right there in the building. At least that's the law in Oregon. There's a couple more. I like these. I use them a lot because I do this kind of work with patients. 97035, Activity of Daily Living, or ADL, counseling. Teaching patients how to do stuff in such a way that it doesn't hurt them. So safe lifting, like I mentioned before, we have runners. They come in with shoes that maybe don't fit, and it's giving them ankle problems or plantar fasciitis. We talk about shoe fit and tie, proper ways to tie the shoe based on the shape of their foot. That's 97035 ADL counseling. And then there's 97535, very similar, again, like the manual therapy and massage. There's some overlap, use your judgment, is therapeutic activity that is not exercise. So like if I'm doing range of motion with a patient and we're restoring cervical rotation by doing PNF and PIR and active and passive range of motion, that's 97110, exercise therapy. If I'm doing breath work with a patient and helping them do some stress reduction, that's 97535. It's a therapeutic activity, non-manual, non-physiotherapeutic help. Let's talk about these time codes and how to use them. So the magic number is 15 minutes, but unfortunately, 15 minutes is not 15 minutes. 15 minutes is 8 minutes to 22 minutes. So there are 15-minute increments, but if you do, let's say, manual therapy, working out a patient's shoulder for 8 minutes, you could bill 15. That counts as 15, but it still counts as 15 minutes when you're at 17 minutes, 18 minutes, 19, 20, 21, 22. Anything from 8 minutes to 22 minutes is 15 minutes. It's one 15-minute unit. If you do anything for less than 8 minutes, you don't bill it. This is why when you get your electric stim machine from the manufacturer, all the times are set to default at 8 minutes, because that's how long you need to do stuff in order to get the insurance company to pay for it. So from 8 to 22 minutes is 1 unit. From 23 to 37 minutes is 2 units, because anything from 23 minutes to 37 minutes is 30 minutes. From 38 to 52 minutes is 3 units, and so on. You can do the math if you're going to do longer visits, or you can find a table or a chart online, I'm sure. Now, what happens if you do 2 different things? I do 8 minutes of manual therapy with a patient, and then 10 minutes of exercise therapy for a total of 18 minutes. Okay, I did both of those things for at least 8 minutes, didn't I? Can I charge both? Because I did both for at least 8 minutes? No, because I only did a total of 18 minutes of timed stuff. That's 1 unit, because it's between 8 and 22. Which one would I bill? You bill the more expensive one, or you bill the one that you did a little bit longer, if you remember. It's okay to bill the more expensive one. That's what they want you to do. That's kind of the standard ethical thing to do. Now let's say I did 13 minutes of manual therapy and 10 minutes of exercise therapy. Only 5 more minutes of manual therapy than I did in the previous example. That's 23 minutes. That's more than 22 minutes. That's 2 units. So now I get to bill 1 unit of each. I get to bill 1 unit for 13 minutes of manual therapy and 1 unit of exercise therapy for that 10 minutes. And so if you're going to bill for 2 units of time codes, you have to have spent at least 23 minutes with the patient one-on-one. You can delve really deeply into this. There's lots of resources online for you to really be able to do this properly. And I really recommend that you do understand how to do this properly because in the long run, again, it's going to be easier and you are going to make more money in the long run if you play by the rules. Simple as that. Next, we're going to talk about our E&M codes, evaluation and management, or exam codes. This is you getting paid for the time you spent on the intake, the history, the exam, coming up with a diagnosis, maybe reviewing x-rays or labs or any other files the patient came in with. That goes into this as well as your decision making and your planning. And so you get paid for all of that, and how much you get paid depends on a few different factors that we'll talk about in a minute. First, let's look at the codes. For a new patient, your codes for evaluation and management are 99202, 99203, 99204, and 99205. For established patients, it's very similar, but there's a 1 where the 0 was. It's 99212, 99213, 99214, 99215, where the complexity of the case increases from a level 2 to a level 5. So a 99202 would be a new patient with a low complexity of issues, like one region, basically self-limiting issue. There is no risk of morbidity or mortality in the case. It's not complicated by any underlying conditions. It's a very simple, straightforward diagnosis and creation of a treatment plan with not a lot of ins and outs and what have you. And this is complicated, way more complicated than I'm going to get into in this video because it's more complicated than I really engage with mentally. So how do I engage with these mentally? Well, first of all, a new patient is anyone who's new to me or who I haven't seen in 3 years. That's the number. If they haven't been in 3 years, they're new again. You get paid more for a new patient exam, by the way, than for an established patient exam, which is why it's important to know when are they new again after 3 years. For the most part, we use 99203 and 99204. Most of the people who come into us, even with neck injury, sprain or strain from a car accident, it's uncomplicated and it's pretty straightforward. It may be severe in terms of injury and how acute their pain is, but it's still pretty straightforward. So that's going to be a 202 or a 203. Interestingly, the more severe their symptoms are, the more complex the case is considered to be, and that upcodes you from a 203 to a 204. I have never used the 205. I have seen insurance companies, when I was working on the peer review committee, raise red flags at the use of 205. 205 is patient comes into the ER unconscious, and the whole triage and history and exam has to be done on the fly, x-rays across the table, blah, blah, blah. Maybe they're bleeding out. That's complex, high risk, probability of morbidity or mortality, etc. That's not what I do. I don't think that's what you do either. So I generally default to 202. If it's a little more complex, maybe they have some underlying issues, some underlying DJD, or an autoimmune condition that we have to consider in our decision making and that we have to investigate in our history and exam, that would bump us up to a 203 or a 204. So again, yeah, it's based on severity, complexity, the number of problems, the risk of complications, also the amount of time that you spend. There's this thing in E&M coding called the time override, where it's even if it's fairly simple and straightforward, if for whatever reason it takes you 45 minutes to get all this information out of the patient, that codes you up a little bit. I'm going to link you in the video description to some very detailed information about how to use these E&M codes, which one to choose. There's tables where it shows you how complex, how many systems did you have to examine, did you have to review previous films or labs before seeing the patient, etc. And then you'll get an understanding of it. Generally, I will say my opinion is that if you stick with 202, 203, 212, 213, you're going to be fine, and it pays well. Here in Oregon, by the way, with motor vehicle and work comp cases, you're not allowed to reevaluate more than once per 30 days unless there's a new issue. So let's say a patient comes in with a cervical sprain from a car accident, and we do the evaluation, their first visit 99203, let's say, and we bill that, and they come in 10 days later and they have now pain down their arm because a disc issue has developed. I'm going to have to re-examine that patient because now there's a new development. So they're an established patient, so it would be a 99212 or 213 depending on those factors we talked about. And I would really want to put in my chart notes that would go with the claim to the auto carrier. Exam was indicated due to the presence of new and concerning symptoms. Even then, sometimes those codes get denied. And in another set of videos, we'll talk about how to follow up on claims because you want to follow up on every claim. And I would call them and I would say, hey, I need you to read these treatment notes. I need you to see the patient had a new complaint that it was concerning because it could have involved neurological damage, and a new exam was warranted. I think you should pay for that. And like 99% of the time, the adjuster will hear me out and pay because sometimes you just need to push a little bit. We're going to talk now about the modifiers, which are those 2-digit or 2-letter appendages that I talked about that get tacked on the end of some codes. There's 3 modifiers that you want to know about. If you're billing Medicare, there's more modifiers, but that's beyond the scope of this here little video. The 3 that you need to know about are 59, 25, and GP. Here's what they mean. 59 and GP, by the way, always go together. 59 means separate and distinct therapeutic procedure. That's what the 59 modifier means. And you want to tack that onto the end of any of your manual therapy, massage, or exercise therapy codes. And here's why. As far as the insurance company is concerned, when you do an adjustment, 98940, they get that bill. That includes patient comes in, you find out how they are, you assess if there's any new contraindications, you do range of motion, you find out where the issues are, you do a little muscle work to loosen them up, you do the adjustment, you check in with them after, you give them basic post-treatment instructions, and you send them on their way. Even though that included a little bit of evaluation and management and a little bit of soft tissue work and a little bit of 97535 therapeutic activity, that's all bundled into the 98940 code. They're considering that when they're paying you for an adjustment, they're paying you for all of that because that's included in the adjustment. The adjustment's not just the setup and thrust. So if patient comes in and I check in and make sure there's no new contraindications and work out their shoulder and then adjust their neck, and I want to say 97140 for the shoulder and 98940 for the neck, that 97140 has to have the 59 modifier on it to tell the insurance company that that was a separate and distinct therapeutic procedure not normally included in the 98940 code. I hope that makes sense. If not, watch that little couple last minutes again and see if it does. If it still doesn't, I would really love that feedback in the comments. I'm trying really hard to make this make sense to you. We also have the 25 modifier. That's the same thing, but for your E and M codes. So 99212-25 tells the insurance company, we did a straightforward, fairly low complexity, established patient exam, separate and significantly separate and identifiable from what we would normally do for the adjustment. And in the treatment notes, you're going to say why. They had a new complaint. They had an exacerbation. Some new information came to light that needed to be investigated. If you do the work, you should get paid, and you will if you code it correctly. Okay? 59 for therapy, 25 for exam codes. The GP goes with the 59. It means physical therapy. I know we're not physical therapists, unless you're a physical therapist, but we're chiropractors. The 59 GP often go together. Some insurance carriers won't accept it without the GP. I don't know of any that will bounce it back if the GP is there. So all your 97140-59 GP, all your 97124-59 GP, 97110 exercise therapy, 59GP, and so on. So let's look at a sample claim and what this looks like. We've got our diagnosis codes that we talked about. Now we've got some treatment codes. Let's look at our claim form and see what the insurance company would be receiving either in paper form or in electronic form, more likely electronic form. Let's say this patient comes in, their diagnoses are M99.01, 02, 03, so cervical thoracic lumbar dysfunction, and M76.01, which is gluteal tendonitis, right hip, and M99.06, which is somatic dysfunction of the hip or the lower extremity. And let's say our treatments were cervical, thoracic, and lumbar adjustments and myofascial release to the right hip for 25 minutes. And that's a pretty typical treatment in my world. How would I code this? I would code those treatments as 98941 for my 3-region adjustment, cervical, thoracic, lumbar. And I would code that 25 minutes manual therapy as 97140-59GP times 2 units, because it was 25 minutes, and 25 is between 22 and 37. On the claim form, each treatment code needs to be pointed to a diagnosis, and pointed means associated with, or you're telling the insurance company, I did the adjustment to my 3 regions for these 3 diagnoses, M99.01, 0.02, and 0.03, and I did this 25 minutes of manual therapy to the right hip. Let's see what that looks like on the claim form. So again, here's our claim form, and we're looking down here at the bottom. Here it is blown up, okay? So up here in the box are my diagnoses. M76.01 for right hip gluteal tendonitis, M99.01 cervical dysfunction, 0.06 lower extremity dysfunction, 0.03 lumbar dysfunction, and 0.02 thoracic dysfunction. So there's all my diagnoses. And here are my treatments. So this stuff over here on the left is date of service, 9/29/23, that's today. And the 11 is the place of service, which means office. We'll get into that in another video. So here's my treatment codes, 97140-59GP. Oh, look, I made a mistake on my claim. Oh, good, this would get bounced, so we get a chance to look at this. 97140-59GP, that's my manual therapy, to diagnoses A and B, gluteal tendonitis, right hip dysfunction. Here it says 1 unit. That's a mistake, it should be 2. Here's my 98941, my 3-region adjustment, to diagnoses C, D, and E. C is M9903, D is the 02, and E is the 01. The order doesn't really matter. And here I put 2 units of adjusting 3 regions of the spine. This claim is going to get bounced back because they're going to say you can't do 2 units of CMT. Yeah, it doesn't make any sense. So I'd get this code back. I would look at it and see what's the problem. And then I would go in and I would correct it. And I would put the 2 here and I would put the 1 there, and then I would resubmit it, and then it would get paid. Well, that was really fun. So that's how we do it. Let's talk about our wellness codes. We call these S codes, not to be confused with the diagnosis codes that start with S for injury. I know it's so stupid. S8990 is a physical or manipulative therapy performed for maintenance or prevention and not restoration. So that's wellness care. The insurance companies don't want to pay for wellness care. Medicare doesn't want to pay for wellness care. Patients want to pay for wellness care. And because you want to have a consistent system where your cash patients and your insurance patients are all going through the same, everybody gets the same stuff, not in terms of treatment, but in terms of documentation so that it's really consistent. You want to make claims for your cash patients, and you want to code for their treatment. Use these codes. S8990 codes are defined by you. You get to decide what they mean, and you get to decide how much to charge. For example, in our clinic, we have S8990A, B, and C, which are for massage. S8990A is a 30-minute massage, S8990B is a 60-minute massage, and S8990C is a 90-minute massage. I guess it goes all the way up to Z, I don't know. But we get to decide if it's a combination of cranial work and organ massage and deep tissue and myofascial doesn't matter. It's all just a wellness massage, and it's based on the amount of time. And for me, for the chiropractic work, it's S89902 for a standard session, S89903 for a 45-minute session where there's going to be a lot of soft tissue work that we do, and S89905, which is a new patient wellness care. I don't know how high those go. Those are the only ones that we use. I get to define what they mean. And in my S89902, my standard session, it doesn't matter how much soft tissue work, exercise therapy, breath work, stress reduction, adjustments, cranial work. It's all about the amount of time that we're spending together in the service of maintenance and prevention, wellness care. So it's just an S89902. And I like those. I like those codes because we define them, use them, have them in there. They'll protect you because it gives you leeway in the treatment room to do what needs to be done with the patient. As long as it's a self-pay patient, then you can do whatever the two of you agree on. And it gives you that flexibility ethically and still be able to charge consistently and have your books be really, really clean. That's my presentation on treatment codes. Now that I'm at the end of it, I'm thinking you might want to watch it again because it is a little more complicated than I led on at first, especially with all the modifiers and everything. But thanks for watching. Dr. Russ signing off. Stay tuned for episode 4.